So good afternoon, everyone. So I'll be speaking about the drug brolucizumab. As we all know that we are using anti-VEGF for mainly these 5 indications: IPCV, AMD, DME, CRVO, CSR. So now the question is, brolucizumab, you ask me that whether I am using as a first line bevacizumab in these diseases. Yes. IPCV, I am using as a first line now. AMD, yes. DME, maybe not. CRVO, yes. CSR, no. So as a first line therapy, I am using in IPCV, AMD, and CRVO cases. Because the initial experience was somewhat, we were getting some intraocular inflammations, retinal vascular occlusions. But in this year or the last year, they have somewhat modified the molecule, and the rate of intraocular inflammation or vascular occlusion is very, very less. So the brolucizumab, everybody knows about the drying effect. It has a very faster, very longer, and very sustained drying effect. That's why this molecule is used nowadays very, very commonly. And that's why the company has increased the price to $28,000 per vial now. So we have analyzed the data of around 100 eyes, and the main outcome measures were BCVA, intraretinal fluid, subretinal fluid, central subfoveal thickness, and pigment epithelial detachment. And these were the number of, most of the patients were having AMD and CRVO. So directly coming to the first the bad things or the good things, the bad things. The bad things we had in the initial 100 cases was 2 patients I had RP RIP, 2 patients had hypopion, and out of which 1 needed vitrectomy. And in 2 diabetic cases, there was an increase in tractional retinal detachment, and these patients were managed with vitrectomy. So the case 1, you can see the drying effect of brolucizumab. It decreases the height of PED, it decreases the IRF, it decreases the SRF, and most importantly, it is the IRF, intraretinal fluid, which is most dangerous for the eyes. And you will ask me whether you can tolerate any fluid. No. No IRF, no SRF. You cannot tolerate any fluid. The retina should be dry. Even if it is IMD case, IPCV case, diabetic, maybe yes. But other cases, everybody wants a dry retina. So brolucizumab, faster effect. Within 7 days, you can see the height of the PD decreasing, the SRF decreasing. It has a longer, remains for 3 months, and it is a sustained effect. So brolucizumab, and with the very 1 to our patients, most of them, more than 80% have 1 to 2 line improvement of vision at the end of 1 year. So case 2, again, 82-year male, wet AMD, 6/60 vision. You can see at the end of even 1 month of follow-up, not even 3 months, you can see the intraretinal fluid has decreased, the PED has gone down, and so this is I had the recent, would you ask me again whether in a 6/6 case you can give Pagenex? Yes, I have given. He was my friend. 6/6, he's a laparoscopic surgeon. 6/6 vision with multiple PEDs in both the eyes. So 6 months back, I injected on his insistence. I was very reluctant. What will happen if something happens? He says, doctor, I have a full belief in you, go ahead. So 6/6 vision, multiple PEDs, a laparoscopic surgeon. So I injected, and believe me, within 7 days, the PEDs were flat. And till date, we repeated in the other eye, and till date, 6 months follow-up, he has not again needed a second repeat injection. So it is the beauty. So you can see the PED going down, the subretinal fluid going down. So diabetic macular edema, these cases, they do need repeated injections. So you have to follow them up for hypertension, a good glycemic control, a good lipid level control. And I don't follow a monthly regime, 3 monthly loading doses, and then PRN as PRN basis. So central retinal vein occlusion, non-ischemic CRVOs, they do very well. 1 or 2 injections are sufficient. Ischemics, they need a longer treatment. So central serous acute cases, I do not give bevacizumab as a first-line therapy. Only if the 2 months have passed, you have exhausted all your options, eplerenone, other drugs, spironolactone, and you've done every other profile. The CSR, the experience was more than 50% cases, they responded. But more than 50%, maybe those who are having a pachychoroid, they are better responders to bevacizumab, and this was more than 50% cases, they did not respond to bevacizumab. So this is the patient. He's a 85-year-old physician. My friend's father, he got RP RIP. So this was the initial period when I used to give Pagenex with injection 0.0 ml DEXA also. So I used to give DEXA also. So in this case, it is an old case, I give DEXA. First injection didn't happen anything. Second injection, he got RP RIP. The vision dropped from 612 to counting finger. And then he was lost to follow up, although he's a friend of mine till now, but his father never comes back to me. So these are the things you should keep in mind by giving brolucizumab. Excellent drug. Thank you very much.
You have shown one case of CSR.
Yes, ma'am. Yeah.
Is it clear-cut indication for anti-VEGF because there is no
No.
opta
Acute
image is
cases
not
for
there?
initial 2 months, we don't give brolucizumab. We follow, stop the steroid if the patient is taking, get his profile done. Acute CSR, no. Only if 2 months have passed, the fluid is not going down, the vision is severely impaired, only then we have tried. But like out of 20 cases now, 10 have responded, 10 have not benefited from the drug. We try brolucizumab, yes. After 2 months, if the fluid has not come even down a little bit, the vision is, we are not having, we are buying. At present, we are not having Octa.
There is no doubt in my mind the drying effect of Pagenex is fantastic. I'll give a short summary in one line. Earlier, 1.5 years back, I was in the government and I used Pagenex for primary indication everywhere. For last 1.5 years, I'm in the private. For treatment naive cases, I am slightly hesitant in using.
Sir, now whatever they, like in the this year, we have not encountered even a single inflammation, sir, or single vein occlusions. So we have tried primarily as in even treatment naive patients, AMD patients, CRVO patients who are having glaucoma and in which you cannot give steroids and you want a sustained effect. So beautiful, very good results.
But
sir.
you said that 2 patients had hypopyon out of 100 in your slide.
Yeah.
So that is almost 2%, which is unacceptably high, isn't it?
In our cases, sir, now, yeah, it becomes, but if you pile up the data, now they are saying even 0.7%. Initial were 4%, initial results, but nowadays the latest is less than 0.7% chances of inflammation.
And those 2 patients, did they respond to treatment?
Yes, sir. So I will share that was an interesting case. So end off, I did a vitrectomy. I put a silicone oil. It is a CRVO case. So after the SOR, I gave injection Pagenex at the end of the surgery also.
These 2 patients
even after he had an infection.
Showing
so she
extremes of inflammation, right? But
Yes.
What about mild or moderate forms of inflammation that you came across?
Oh, they are taken care of by post injection topical steroids only, ma'am.
Are you sure those hypopyon cases are only because of injection per se? On that particular day, you might have injected few other patients also.
Yes,
Whether
yes,
they
ma'am.
incurred that?
Though this is a very clean lady, no diabetes, no hypertension, chronic CSR patient. So no idea, man, why it happened.
Thank you, Dr. Balbir. That was a very good talk. I think, but with time, I think overall, I think we need larger data with Pagenex. Obviously, it works well, but what we basically, I think, as Sir was pointing out, I think the confidence level needs to go up with more robust and data with clear treatment protocols where everybody follows the same treatment protocol, and then we study and then we kind of safely use the drug more often. Thank you.
Thank you.
Anubhav, you are next.